Welcome to Integrative Oncology Talk, where we discuss the latest science and opinions from leading voices in integrative oncology. Integrative oncology utilizes complementary therapies and lifestyle strategies to help those affected by cancer, using personalized approaches and evidence-based recommendations. This podcast is hosted by Dr. Santosh Rao, a medical oncologist and integrative oncologist, and Dr. Judith Lacey, a supportive care and integrative oncology physician, with support from the Society for Integrative Oncology, an international multidisciplinary organization whose mission is to advance the science and education of integrative oncology worldwide. The views expressed on this podcast do not necessarily reflect views of the participant's workplace or SIO and are not meant to offer medical advice. The information, opinions, and recommendations in the podcast are for general information only. Before making any changes in your healthcare or lifestyle, please discuss with your healthcare provider.
Hi, everyone. Welcome to Integrative Oncology Talk. I'm really excited for our guest today, Jennifer McQuade. She's an assistant professor and physician scientist in melanoma at the University of Texas MD Anderson Cancer Center. She has a very interesting history. She completed a master's in science in clinical and translational science in MD Anderson's Advanced Scholars Program. She also holds a master's degree in traditional Chinese medicine after spending time in China as a Fullbright Fellow. Her research includes lifestyle factors and their influence on melanoma biology and the anti-tumor immune response, as well as integrative therapies for symptom control in cancer. Today, we'll be talking about the microbiome and its impact on cancer and the therapy for cancer, as well as translational research in integrative oncology. Hi, Jennifer. Thank you so much for joining us today. Really excited to talk to you.
Thank you for having me. I'm very excited as well.
Well, I wanted to just jump right into it. So I know you have a really fascinating background, and let's just start there. I wanted to ask you what led you to being an oncologist and then developing, you have a variety of interests, but just reading your bio, you ended up going to China and got a master's in traditional Chinese medicine. I want to know about all of that, and then how you started doing research
Sure.
you have a variety of research, obviously, but some of it is related to integrative oncology and the microbiome.
Yeah, absolutely. So I was one of those people that wanted to be a doctor from, the time I was 5. And I always said that, but it was about a fascination with the human body. It wasn't necessarily about the taking care of patients, which I guess makes sense. 5-year-olds don't think in that way. But then I got to college and there were so many interesting things to learn. And I felt very confined by the pre-med curriculum and kind of that cutthroat competitiveness as well within the pre-med student population. And so I actually went to my advisor and he said, you've got plenty of credits, next semester, don't take another chemistry elective, take something that you know nothing about, but are really interested in. And so I took a course on Chinese political history. And I just found it fascinating. And at the end, I went up and I said, I want to learn Chinese and go to China. And he was like, okay, let's take a step back a little bit. But I took a year of college Chinese and then I moved to Taiwan, really not sure at this point what I wanted to do, if I was going to come back to medicine or not. And I spent almost 2 years there studying Chinese and teaching English. And I was actually just about to leave and spend a year backpacking. And when I called home, my mom had just been diagnosed with breast cancer, which she is fine now. It was a stage 2 breast cancer. She had a mastectomy, chemotherapy, radiation, and she is just fine now. But, I obviously wasn't going to go gallivanting around the world while she was going through these treatments. And so I moved to Houston, actually, where they had moved while I was living overseas, and spent that time with her. So that was 22 years ago in June.
Wow.
I actually ended up during that time, again, still not knowing exactly what I wanted to do, but maybe thinking business. I took a job at Enron and then at UBS Warburg in energy derivatives. And it was interesting, but not very fulfilling. And so I started exploring the idea again of going back to medical school. But I was also really interested from my time in Taiwan in integrative medicine and specifically in acupuncture. And when I had taken my mom to the to the oncologist, and I was concerned she was about to start chemo. Is she going to have nausea and vomiting? I know that chemotherapy can be acupuncture can be effective in that setting. I said, okay, let's go down to Chinatown. We'll find an acupuncturist and see if there's some integrative medicine that could help you. And we went down there, and he said, well, you haven't started chemo, so you don't have nausea, vomiting. I don't really have any, we don't need acupuncture right now, but we'll see if we can do it later. But in the meantime, I want her to take these herbs. Mm-hmm. I said, well, what's in them? And so he tells me the names in Chinese. Never heard of them. He gives me, a book, and it has, the Latin names. Never heard of them. And I said, what do they do? And he said, well, they tonify blood. Mm-hmm. What the heck is tonify blood? I know she had to stop her ginkgo biloba because of, bleeding risk before surgery. So what does this mean? And I said, do you have any literature on this being safe to combine with chemotherapy? And he, hands me a book, and, it's all preclinical studies, and in 5 mice it did this. But my question was, is this safe to use with chemotherapy? And I knew, obviously, the other resource would be her oncologist, who was phenomenal. But I also knew that her oncologist likely didn't know about these medications, and that the no, don't use them would likely come from the I don't know, rather than there is literature suggesting, yes or no. And so I said, I have a degree in biology. I speak Chinese. I can figure this out. We'll take them. And I went home and I got on the internet, and it was, all I could find was sales and marketing, no actual resources. So with this background, when I was starting to explore going back to medical school, I actually saw that there was a school of Chinese medicine here in Houston. And so I started taking courses there in the evenings. I thought it was really fascinating. And what I learned at that time was that I loved patient care. Mm-hmm. And so I really enjoyed that interaction. But I still, in my training, wasn't getting a tremendous amount of evidence. I was learning a bit more about how to do acupuncture instead of specifically learning about, what the studies were either supporting or refuting the use. And I wasn't sure at the time if that was because the literature didn't exist, or I wasn't being taught it, or wasn't reliable. And so in the setting of this, I decided that if I was interested in, integrative medicine for cancer patients, that what I wanted to do is I wanted to become the oncologist that did that research and used my background in training and kind of brought together both worlds.
Wow. So that was your first foray into integrative oncology with your mom in the center of it. I think it's fascinating. I always ask people kind of how they started, because most of us had some kind of inspiration, and it's you're no different, that you went through years and years of training after you had that initial kind of seed of inspiration, and look at you now. You've really kind of putting it all into practice, which I think is great. I want to dive into kind of some of your research, because there's just a lot to talk about, and I think it's really fascinating and informative. So I know that you probably do research in a lot of other areas as well. You're a melanoma specialist, and obviously a lot of your research is related to melanoma and immunotherapy, et cetera. But for integrative oncology, I think our audience will be very interested in some of your research regarding lifestyle and the microbiome. So let's talk about that, okay? And for anybody who doesn't know, tell us a little bit about the microbiome, its importance, and kind of some of the ways that it can be modified, through various factors.
Sure. Okay. So the microbiome is basically these trillions and trillions of microorganisms that live on us and in us. And so these are what are called, commensal bacteria. So they're kind of good bacteria, right? And then we have our pathogenic bacteria that we try to fight off. But we essentially have this symbiotic relationship with these microorganisms. Bacteria, well studied. We're starting to learn a little bit more about kind of fungi and viruses. And so we all have distinct microbiomes, and we have distinct microbiomes within each niche: our skin, our mucosal linings, and even now we're finding out in tumors as well. But the part of the microbiome that's really been the most well studied, and specifically with relation to human health, is the gut microbiome. And the gut microbiome has a very intimate relationship with the immune system. So you have the lumen of the intestines, you have all these bacteria that are there. You want to keep the good bacteria, get rid of the bad bacteria. You have your mucosal layer. And the microbiome actually feeds the enterocytes to help form that nice thick mucosal layer. And then right on the other side, you have kind of the mucosal immune system itself, the draining lymph nodes, and then it impacts systemic immunity as well. So there had previously been quite a lot of work around looking at the microbiome in autoimmune diseases, and potentially, things that could kind of set off that inflammatory cascade.
Like ulcerative colitis or stuff like that.
Yeah, like ulcerative colitis, or even things like most well studied for sure with kind of the diseases of the gut. But even allergic diseses or other autoimmune diseases such as like rheumatoid arthritis.
So how do you define like a good or bad bacteria?
That's a good. So there are some things that are clearly pathogenic, and there are some things that are clearly beneficial. So, for example, Fusobacterium has specifically been linked to risk of colorectal cancer. And there are very clear mechanisms that have been worked out in terms of the pathogenesis of that. There's, as far as the good bacteria, and we'll come back to this a little bit. So good bacteria tend to be associated with health as opposed to disease across multiple different disease types. And there was a really, really beautiful paper that was just published out of the Netherlands this week. They looked at, I think it was like 8,600 individuals, in multi-generational families. And they asked them about all the stuff, right? All the diet, all the exposures, early childhood, everything. And then they captured all of their diseases and comorbidities. And what's really interesting when you look at that correlation heat map is that the bad stuff and the good stuff line up across the diseases, right? So you have bad stuff that's associated, Fusobacteria may be very specific for colorectal cancer, but if you're looking at kind of the overall ecosystem and not necessarily pathogenic bacteria that we know, directly cause an issue, but those associations, the bad stuff is associated with, bowel diseases and with heart attacks and with strokes. And so there does seem to be this kind of overall good microbiome.
I mean, this is where it gets very interesting though, because it's hard to, because this is a relatively, I don't know how new this concept is. I mean, how long has the microbiome been on the radar?
Gosh, that's a good question. There was the microbiome, but then there was really the development of our ability to deeply characterize it. And that was, kind of late 90s, early 2000s.
Because I think it's easy to kind of keep going in this direction and start, it's fascinating. And, yet in our medical training and stuff, I did not learn a lot about the microbiome back then. And, we're taught that cancer is partly from, your inherited risk. And then, a lot of it recently is about lifestyle, smoking, obesity, et cetera. And, how much does the microbiome influence that? And obviously it would be different for different cancers. You're a melanoma specialist. We think of sun exposure and your race as probably the primary factors, and where you live, et cetera. But a lot of it is sun exposure. So that may be different in something like that versus colorectal cancer. How much of an influence do you think the microbiome has in various cancers? And do we have a good sense of where it's most impactful?
Yeah, absolutely. So, as far as where it's most impactful, I would think that those are the gut luminal malignancies, where we have a direct interaction between those microbes and the mucosal surface, right? Okay. And there's clear causal links with carcinogenesis. Now, again, very unlikely that somebody's, colon cancer is strictly caused by Fusobacterium, right? But the other part of it as well, and most colorectal cancer patients don't have that Fusobacterium. So people get cancer for different reasons, and it can be because of their genetics. It can be because of the environment. The environment then influences the microbiome, right? So that exposure, so the diet, obesity, all of these other things that are linked to colorectal cancer, the microbiome is kind of an integrator of those things. Now, is the microbiome causal? Does it mediate that effect? There's some data suggested is, but the question where we are with a lot of the microbiome field is how much of it is an association versus versus truly causal, and how much of these things are kind of is this a bellwether of, good health, meaning higher socioeconomic status, right? Diet, exercise. And with humans, it's really hard to pull all those things apart.
Sure.
Because patients that have higher socioeconomic status, right, they're the ones that are eating quinoa. Mm-hmm. And so, mouse models there certainly become very helpful in that. But
speaking of
those, or H. pylori, right, in the stomach, right. That's clearly causal.
Speaking of, I want to ask you later about transplant, but speaking of mouse models, I've seen studies that are fascinating regarding fecal transplant or microbiome transplants in mouse models and responses in the tumors, right?
Yeah.
Is that response to therapy, or does the cancer itself? There's obviously mouse models with obesity, which is fascinating too. And it starts making you think, is the microbiome that central to this process?
Yeah. So if we go back, so let's just take, kind of response to immunotherapy. Immunotherapy, these checkpoint inhibitors completely revolutionized cancer treatment. They work by essentially, taking the brakes off of the immune system and now allowing it to go in and recognize cancers. Now, when we do mouse models, what we do is we buy mice either from, Jackson Lab or from Taconic Lab, or kind of the two big ones. And we buy these mice. If you give the mouse, if you inject them in the subcutaneous tissue or somewhere else, right, with a tumor cell line, and now you give them chemotherapy, it generally doesn't matter whether you got it from Jackson Lab or a Taconic Lab. They're genetically identical. These are not wild mice. They're genetically identical C57 black 6 mice. So Tom Gajewski at University of Chicago, what he saw is that when he got the Jackson Lab mice and he gave them, cancer and then gave them immunotherapy, their tumors shrunk, but the ones from Taconic didn't shrink. And It's like, they're the same, they have the same genetics. I'm injecting them with the same tumor, different than humans where there's tons of heterogeneity. So why were they responding differently? So he starts to think, they've kind of come from different environments. Environment impacts the microbiome. And sure enough, they have very distinct microbiome profiles. So now when he took the Jackson lab poop and did a fecal microbiota transplant into the Deconic lab mice, he was able to transmit responsiveness to immunotherapy via this fecal microbiota transplant.
Wow.
Right. Now we're getting at causality. So then the question became, is this relevant in humans? So this is back in 2015.
Mm-hmm.
So then 3 groups simultaneously, Laurent Zipfel's group in France and Tom's group at University of Chicago and Jen Wargo at MD Anderson, started collecting fecal specimens on our patients that were starting immunotherapy. And what they each saw published in papers in Science in 2018 was that there were distinct signatures between responders versus non-responders to immunotherapy. And now, again, if you took actually this time the human poop, and now you go into a germ-free mouse, so a mouse that is grown up without a microbiome, you do a fecal microbiota transplant into that mouse, and then you treat that mouse with the poop from a non-responder, human, then that mouse's tumor will not shrink. Whereas if you treat it with poop from a responder human, now their tumor shrinks with immunotherapy. So
That's fascinating.
Crazy.
Fascinating. Yeah. Well, I want to get into that in a second because you've done a lot of awesome research with immunotherapy and the microbiome. Just to finish up this topic, I'm curious about whether we know, related to diet. I know that you've been getting into research with nutrition. How much does our farming practices, antibiotics have an effect on the microbiome temporarily, right? So if somebody just got antibiotics, whether they're on therapy, whether they're not, it has an effect on the microbiome, and there's some implication potentially on response to therapy, right? What about, because there's all these questions about why, somebody who moves from Japan to the U.S., suddenly has, an increased risk of breast cancer if they spend their teenage years here, for example. So we know that. And I think people have talked about obesity and stuff like that, but that's not necessarily the whole answer. And there's all these unanswered questions, right?
Yeah.
So, I think the microbiome is one potential, source to look at. Do we know anything about, regionally around the world, what kind of farming practices have an influence on what's called, quote unquote, a healthy microbiome?
Yeah, it's a really good question. And I mean, specifically, right, pesticides and kind of the use of antibiotics and farm, right? And then if you have organic farming versus inorganic. And so far, it really hasn't been kind of neatly untangled. But certainly plenty of reasons to think that it would influence it. I think the other part, beyond the farming practice is then kind of our processed foods. And so here I'm not even talking about, right, we all know that people, when you leave from an agrarian place and you come, to the US, you're eating more red meat, you're eating, less whole foods. And so certainly that's going to change the microbiome. But also the additives that we put in there. And so specifically there, emulsifiers, which we use to make many processed foods more palatable, those have actually been shown to really have an impact on the microbiome in a negative way.
And how quickly, is it modifiable? I mean, I've heard different things, but I'm just curious because some of this, like, take me through a timeline. Like, obviously you get a lot of your microbiome if you're breastfeeding, right? That's your first introduction, or if you're getting breast milk some other way. But basically, you have your childhood, coming from your mother a lot of times, but your childhood microbiome. Then you have your lifestyle directed influence on that, right? How much of it is baked in if you're an adult? Let's say you're a woman who's 45 and has breast cancer. How modifiable is your microbiome? How quickly does it modify? And then, how long does that last? Do you have to stay on the same diet?
Yeah. So a few things. So one is we know that the core microbiome in an individual is remarkably stable over time, if we are not actively trying to perturb it, or maybe not actively, if we're not passively perturbing it, say, for example, with broad spectrum antibiotics, right? Now, if we try to favorably modulate the microbiome, if we do a fecal microbiota transplant, it's almost immediate. If we are using diet, then there have been previous controlled feeding studies that basically show that within about 2 weeks, we can modify either the microbiome, or what actually might be more important is its metabolic output, right? So we all have these different bacteria, and I might have the particular clade of bacteria that is involved in fiber fermentation for me. You might have a slightly different one. When we increase the fiber in our diet, you may more selectively bloom that one that's already the dominant population in yours. I might bloom this one. So it's not so much about the specific bugs. And that's what that paper where they kind of show these, that a lot of bacteria, good bacteria associated with health, bad bacteria associated with many diseases. Those good bacteria are also associated with each other. And so it's really about the ecosystem and not about individual bacteria, but it's also about what they are doing and their function there. So we can change the microbiome in about 2 weeks. However, yes, to sustain that change in the microbiome, we have to sustain the diet.
And the diet that's been shown to be helpful, I mean, I was just reading some of your papers before, is things like high fiber, plant-based. Am I right?
Yeah. Yeah. So it's nothing radical. It's the same exact diet that, is the American Cancer Society, American Institute of Cancer Research, recommendation for cancer prevention. It is, the same as the American Heart Association diet. It's the same diet that's, recommended by the World Health Organization. So it's not a magic diet. It's just, eat food, mostly plants.
Okay. And then what about, I'm curious about probiotics as well. And we'll talk about this in the context of immunotherapy, but, probiotics are kind of like a huge fad nowadays. It's not regulated necessarily. There's a lot of variety in what people get. And then you also can get probiotics from your diet, and I'm just curious about the influence of all that. Like, I think we've taken it just taken it for granted that you have all these probiotics in yogurt, for example. Yeah. What do you think that's a positive thing? Is it more complicated in different settings? Is it, a lot of times when we talk about natural products, for example, I think we kind of ignore whether somebody's eating turmeric in their diet, because the dose is limited. Is it the same with probiotics where you kind of ignore whether somebody's, eating kimchi rather than taking a pill? Yeah.
So I think you're making really important distinctions there between, supplement-based and diet-based. So the first thing, if we think about probiotics, is what are the bugs that we're giving somebody? And are those the right bugs? And the answer is that 90% of the bacteria that live in our gut are anaerobic bacteria. They're very difficult to culture, right? The things that are easy to culture are those aerobic bacteria, which happen to be the same things that, help make yogurt and sauerkraut. It's the stuff that, humans have been using for thousands of years. Now, if you distill it down and you put it in a pill and you're giving it at mega doses of, colony forming units, those bacteria can actually then start to crowd out some of the other good bacteria. And there was a really beautiful study that was published, I think, in Cell by the Israeli group. Ron Siegel's group. And what they found is they took, because then the question is, okay, what about antibiotics?
Mm-hmm.
After antibiotics, should I be taking, probiotics? So they took humans and mice. They gave them broad spectrum antibiotics. And then they did one of three things. They gave them a fecal microbiota transplant from their pre-antibiotic specimen, immediately restored their ecosystem. They do nothing. Mm-hmm. And over time, we restore our ecosystem. We like homeostasis, and we kind of return to that. And that takes about 6 to 8 weeks. Then they gave them single strain probiotics. And that group actually had the slowest recovery. And they took the filtrate out from, kind of a co-culture. They took the filtrate out and, then put that together with other bugs. And it was basically the filtrate from that bacteria. So it's secreting something that was actually inhibiting the growth of other good bugs. So kind of competitive exclusion. Now, so then, yes, the question becomes, what about yogurt and kimchi and sauerkraut and all this? And based on that stuff, what I previously told my patients is, if you like yogurt and you like sauerkraut, then eat those, but, don't go sitting there eating, 6 to 8 servings a day to try to change your microbiome. Now I've changed my tune. There was a really, really nice paper that was just published by Justin Sonnenberg's group at Stanford. And what they did is they added high fermented foods to people's diet. And they targeted actually 6 servings a day, which is quite a lot. Mm-hmm. They were allowed to eat their normal diet. And they gave them instructions, on what high fermented foods are, which is basically that whole section of Whole Foods, right? And, they could choose sauerkraut or choose guts, or they could choose yogurt or kefir or whatever. So what they found with that study is that they actually increased the diversity of the microbiome.
Wow.
And so then they took those foods and they cultured the bacteria that are present in those foods. And these are naturally fermented foods, right? So they're not single strain, they're multi-strain. But again, it's an ecosystem that is working together. And the other part of it is now you're providing both the probiotic, the bacteria, but also the prebiotic, right? So the cabbage, the fiber that it is eating. And so then you say, okay, well, you increase that diversity. Is it just all those bacteria that you just ingested? And it was not, right? They were actually making the overall ecosystem more healthy and rich as well.
Fascinating.
So that's kind of one of the next studies I want to do, is to look at that. And
yeah, I mean, this is all so impactful, right? Because we just don't know unless you study it. I want to get into the immunotherapy side of it because, and forgive me, I don't know if there's been as much research in chemo, because I know that you've talked about immunotherapy. So you let me know if there's, studies that show an impact in chemotherapy the same way. But the immunotherapy studies, I think are very interesting. And yes, immunotherapy is used in a majority of cancers almost now. It started with melanoma and renal cell. But now is used in probably a majority of cancers in some way in terms of checkpoint inhibitors. And, tell us a little bit about what you found and what is currently being studied in terms of the impact of, microbiome changes, differences in diversity. And then we can get into, impacts on probiotics and those kind of things, because I think that those things, first of all, have a direct impact on what we do in integrative oncology. And I think integrative oncology is this kind of, somewhat sometimes vague field where I think many of us, when we think about the microbiome, that's one area that we really feel like we want to, kind of really focus on, probably more than other clinicians. But it's not entirely clear yet how this translates. And I know that this kind of research has a very clear, directive, at least in terms of some of the impact on people who are on certain therapies.
Yeah. Yeah. And I think it's also, just kind of that idea too of the integrative oncology community, right? Where we always want is kind of, is more rigor and mechanism, right? And I think the microbiome has actually lent really a lot of credence to the type of research that we do around, diet, right? We're not hand waving. There's a very measurable thing that we can change, and that, outside of of our hands and diet hands, just with the fecal microbiota transplant, you can change it. So now it becomes relevant again.
Yep.
So with chemotherapy, you're right. So most of the research has been done with immunotherapy, but actually first not with checkpoint inhibitors, but actually with stem cell transplant, which is really kind of our original immunotherapy. And that was really brilliant work that was led by Marcel Van Brink at Memorial Sloan Kettering many years ago. And essentially showing that those patients with a higher diversity of their microbiome had improved outcomes in the form of decreased transplant-related mortality and decreased risks of GVHD. And so now in that setting, right, these patients are slammed by antibiotics, frequent hospitalization. That might be a setting actually where the diet's not even as important. It's more about, kind of these other exposures. Some data in chemotherapy and some in radiation. Those are mostly kind of smaller studies. Where people have really been interested is with the checkpoint inhibitors, and really kind of coming out of that early mouse work that I was telling you about. So essentially, the research that we've been doing is, again, looking at bacteria associated with response versus non-response to immunotherapy. In the MD Anderson cohort, then those beneficial bacteria are really bacteria that have known roles in fiber fermentation. So bacteria that have known roles in fiber fermentation. Now, again, going back, the bacteria that we see associated with response in our US cohort are not the same as those associated with response in the French cohort and in the University of Chicago cohort. And so, again, we kind of come back to this: what is a good bacteria, bad bacteria, the ecosystem, what it's doing, et cetera. But essentially, Jen had initially published a paper in 43 patients treated with immunotherapy, looking at associations between these bacteria and response. We expanded that and published work in Science on Christmas Eve last year, actually, that then showed that in 293 patients treated with systemic therapy with melanoma, that we again saw these same kind of fiber fermenting bacteria floating up to the top in terms of response to checkpoint blockade. So then the question was, okay, these are associated with fiber intake in healthy populations. Is diet important in, advanced cancer patients receiving treatment? And there's some reasons, again, kind of from if we just think about it, why it might not be, right? We all, is cancer and all of our treatments and all of the exposures and the antibiotics, is that just going to completely outweigh everything? So we integrated a lifestyle survey in with our microbiome collection. And what we found is that our patients that are consuming sufficient fiber actually have a higher chance of responding to the immunotherapy, prolonged progression-free survival. Now, again, as we talked about, that's correlation and not causation. We did control for basic tumor characteristics and things that are prognostic in melanoma. The association held true. But then importantly, we also then went back into a mouse model, working with Giorgio Trincieri's lab at the NCI. And there, it turns out, right, mouse chow is actually a beautiful source of fiber. It's all whole grains. And so the way you do fiber studies in mice is you fiber deprive them. And now you take it down to 2% fiber. And kind of a purified ingredient diet. And so now you give the mouse the high fiber diet or the fiber deprived diet, give them cancer or treat them with immunotherapy. And the first thing that you see is that dietary fiber change very rapidly and reproducibly shifts the gut microbiome, in these preclinical models. They are much simpler creatures than we are, but within a few days. Now, when you treat the mice with immunotherapy, the mice who have the high fiber diet, this is a model where we know it is responsive to immunotherapy. And sure enough, mice tumors respond to immunotherapy. However, those that had the fiber deprived diet, their response is significantly abrogated. And when you repeat the experiment and you do this in germ-free mice without a microbiome, then you do not see that same effect. So suggesting, again, because fiber can do lots of other good things, so this suggests that this is actually microbiome mediated.
And you've done studies, and I've seen some of them, that you can really look at predominant bacterial strains in the gut and show a significantly different response, whether it's toxicity from immunotherapy versus response, which, opens up a whole bunch of questions about, someday should we be measuring, patients before they get their therapy and maybe even modifying their microbiome to, modify that response if we want to, because, as a clinician, I'm sure you're in the same boat as me. When I'm giving somebody combination immunotherapy, I give them the potential risk of toxicity, but I don't actually know who's going to get, colitis or any of those side effects. And I also don't know who that patient is who's going to get a complete response, right? Which is obviously what we want to know. And, we have things like PD-1 levels in certain tumors, and there's tumor-specific things, but this seems like a very, very important host factor that could be modifiable, obviously.
Yeah. So again, it's kind of the microbiome is both a biomarker and a target, which is pretty cool. So we can modify. We can't change, right? I can't change my germline genome. I don't want to change the tumor genome. I just want to eradicate the tumor. But this we can actually modify. But are we at the point where we can, profile a patient's microbiome and, then say, we're now going to do this personalized intervention for your microbiome? That's where I want to go. We're not there yet. So we're still learning. Again, is it the specific taxa? Is it the function? Is it the ecosystem? What is the best way to modify the microbiome? We also need kind of real-time data, right? Ideally, I would love to have that data before I start immunotherapy and then change their microbiome, prime the immune system, and then come in with immunotherapy. But, we don't get 24-hour turnaround on microbiome sequencing, much less for our tumor sequencing either, right? So
I have some follow-up questions. One thing, first of all, is probiotics. What is the deal on probiotics? And specifically with patients getting immunotherapy. I know you've talked about this before, but I want to hear from you. What are the concerns, I guess, with probiotics use, especially the way they're offered nowadays, kind of over the counter?
So in our study, about 30% of our patients were actually taking probiotics. And We can think about why were they taking probiotics? Well, we excluded the patients that had recent antibiotic exposure and just those that, were in theory taking it just for health promotion. When we look at those patients that were taking probiotics, over-the-counter probiotics, they actually had decreased survival with immunotherapy. Again, we come back, correlation does not equal causation, right? Again, why did they feel the need to take these probiotics? But it's certainly room for caution. And now, again, we go back to a mouse model. Now you take that model where you took the patients who had a complete response to immunotherapy, you do the FMT into the mice, and now you give those mice one of two commonly used over-the-counter probiotics. You lower the diversity of the microbiome and you diminish response to immunotherapy. And so again, this non-discriminate use of probiotics is definitely something that I would avoid. Now, does that mean that probiotics are always going to be bad? I think we need the next generation of really rationally designed probiotics. So let's figure out, and again, it's probably not going to be a single strain. There's really nice work where Ken Hondo in Japan, he takes, where he has like 8 bacteria that he finds induce an immune response. And then there was 5 other bacteria that seemed to kind of come along with it, but they didn't directly impact the immune response by themselves. But again, he adds those together. Those 13 are even more powerful than the 8, even though the 5 couldn't do anything by themselves. And so, now they take that into clinical trials. Or there was just recently a paper published in Nature Medicine in renal cell carcinoma and presented at ASCO last year. And they did a randomized trial between Ipi-Nivo versus Ipi-Nivo plus, in this case, a single strain probiotic. Now, interestingly, the primary outcome of that trial was actually, to increase the abundance of that particular bacteria in the stool. It did not meet its primary endpoint. It actually didn't do that. There were only a few patients where they actually increased it. However, the progression-free survival split in that trial was just really remarkable, which is how it got into Nature Medicine. And so, of course, more investigation and kind of comes back. The fecal microbiome is not necessarily what's going on at the colonic interface, right? And so sometimes it's just, there have been other studies with probiotics where they do sampling all the way through the GI tract and then look at the feces. And sometimes if you're giving the probiotics and you see an increase in that bacteria, which you would think would be a good thing, it might actually be just because you're shedding it. So more stuff to come there.
I mean, I think it's probably premature for clinicians to really use this information, but I know people are interested in, within functional medicine, or if you go to an integrative provider that's interested in the microbiome, there are commercial tests that are available. I mean, what are your thoughts with any of that? Because most of us probably don't know enough, or maybe nobody knows enough to really use this in a clinical setting yet. But what are your thoughts with people who say, okay, well, obviously this is important, and you can get a test that will tell you, hey, you're not processing this type of food. You have this abundance of bacteria. I've seen this kind of tests before, but it's not easy to interpret, let alone do something about.
Yeah, because then the question again, if you're not processing that type of food, does that mean you shouldn't be eating that type of food, or that you need to eat more of that? And again, I think it's just premature. I think we're using a platform that should be research-based at this time, and we just can't make decisions on that. Now, what needs to be done, right, is the study of, can you personalize this? Can you get that report? And if you intervene on that, and what would that intervention be? Then can we improve outcomes? So then it comes, is it all too premature? This comes back to diet. in my mind. Again, high fiber plant-based diet associated, even if we don't shift the needle on immunotherapy outcomes, which is a high bar, but one that we're trying. Even if we don't shift it, then we know that we are decreasing risk of secondary malignancies. We are decreasing risk of cardiovascular disease. We are improving longevity, and people feel better too. And so that is something that I think is a message that we can go ahead and put out there.
So I want to get into what you talked about with modifying the microbiome. And we talked about fecal transplant, which I find fascinating. I mean, one of the questions, though, is how you find the right donor, because it's so complicated. You can look for whatever you want, whether somebody is technically, quote unquote, healthy and thin. But if it has such a big impact on potential risk of cancer and other, how do you know who a good donor is? Is it just somebody who's a responder to immunotherapy, for example? And then there are other options that are kind of, being researched now with, more kind of targeted strains of bacteria and things like that. If you could comment on those two things.
Sure, absolutely. So donor selection is much more challenging in this space than it is, say, for example, for C. difficile, right? So C. difficile after antibiotics, a huge outgrowth of this pathogenic bacteria, and the microbiome becomes profoundly dysbiotic. And so any run-of-the-mill healthy donor, right, is probably completely sufficient for restoring the microbiome. The question is really, do we know enough about what is the microbiome that's associated with response to immunotherapy to be able to select donors from that? And, what a lot of investigators have done instead is just use the poop from a responder to immunotherapy as the donor, with the idea that we might not completely understand the microbiome yet. But, this was, say, a sample also that might have induced responses to immunotherapy in mice, kind of acting as the avatar. And so we don't understand, but let's give them the whole ecosystem and then see what happens. So there were actually just 2 papers that were published in Science last year using this approach. And so these are in patients who are actually refractory to immunotherapy. And they then they continued on or re-challenged with PD-1 immunotherapy, which the response rate to that, if you just re-challenge in somebody that's refractory, is 10, 12, 15%. They then added fecal microbiota transplant, and both of them saw response rates of around 30%.
Wow.
Yeah. Now, promising. However, these are both phase 1 studies, right? 10 to 15 patients each, primary outcome being safety and engraftment. So if we go back to those things, what is it? Safe? Yep. No badness. Was it, did they engraft? And this was actually a big question because, again, we're not dealing with a profoundly dysbiotic state like C. diff. Yes, they were able to engraft. But then this also gets into this donor effect. Both of these donors were complete responders in the Israeli study. Both of they were complete responders. They both profiled their microbiome. Everything looked really good. All of the responders happened to get one particular donor's specimen. And nobody that got the other donor specimens responded. Now, small study. Who knows if that's reproducible? But there is some stuff in the IBS literature as well about kind of super donors. Again, we've got to be able to better define.
And engraftment, you mentioned engraftment. I mean, it's in a normal patient who doesn't have C. diff, it's not a sure bet that they're going to engraft without giving them some kind of antibiotics or something else. So that's another hurdle that we have to cross.
Yeah.
Are these things starting to penetrate medical school, curriculum?
I don't know.
I don't either. I was just curious. Or in oncology fellowships, I know that many fellows and scientists are now really interested. I mean, this is a very hot area for research. So I would assume that they're interested. I just don't know how much, this is part of the core curriculum, if anything.
Yeah, I don't know. And actually, it's a good question. I don't even know if within our oncology fellowship,
so you don't have
on them. I talk to them all about it in my clinic,
but they haven't asked you to give a lecture or something in the medical school.
No, but Jen Morgo might have, or somebody else, right? They could be still getting it. I'm not sure. Well, or maybe they go back and they're like, oh my God, that's all McQuade talks about. So we don't need to add it to the curriculum.
Well, we have a few more minutes, and I just wanted to ask you about, your about melanoma. Mm-hmm. And obviously rates of melanoma are going up worldwide, which is a big concern, obviously. First of all, is that all? What is the specific cause? Is that all because of climate change and ultraviolet radiation? Is it, is there something else that we're missing? Because I don't think we spend more time outdoors than historically people did. So that's my first question. Yeah.
So a lot of it, the majority of it actually is, is UV exposure. It's very, very UV linked, but the question is, why is it rising? So I would say not even so much climate change as the ozone. So there's really good data out of Australia showing that. But even there, sun behaviors and sun protection really matter. So they had rates that were skyrocketing. And they implemented a huge campaign, that's taking it down all the way to kind of children's level, all the way up to adults about, hats and sun shirts and sunscreen. And it was very successful, and their rate then started to decline.
Okay.
Now, of course, there's a lag, right? But we actually can do that. The other big thing is tanning beds.
Right.
And that's huge. And especially, that's really kind of our young women. Now our older, we have that bimodal thing. And then the older people, now, why is it increasing now? Well, people are living longer and they've got cumulative damage from a lifetime of sun exposure, of the farmer, of the pilot, or whatever. And so that will also take a while to decrease. Now, the other part of it is it, partially also, do we have overdiagnosis? And so, we certainly want to identify and remove these culprit lesions, but most primary melanomas will never end up metastasizing. And so we need to better understand, what are the ones that will, and how do we intervene upon those?
And then specifically, my understanding is that what's worse is, like you said, tanning beds, or if you sunbathe and you're getting a high amount of sunshine direct for a short amount of time, that is worse, especially for light-skinned individuals, than if you're kind of out playing basketball, regularly, and you kind of have clothes on and you wear, all that kind of stuff, right? There's the chronic versus the acute.
Yeah, there's the chronic versus the acute. It's like, and again, it's cutaneous melanoma is a disease of white people. Most of the time when we have people with multiple family members with melanoma, they're very rarely as a genetic component, extraordinarily rare. Instead it's that they all have the same complexion like mine, right? And then grew up, at the beach.
Yeah.
And with the sun. And a lot of it too is kind of that early sun exposure too. And so we really need to watch our kids.
And so what is, just for people listening, what's your recommendation for sunscreen? It's interesting. I live in Arizona. You're in Texas. I see a lot of people with low vitamin D levels, which is interesting. So I think we tell everybody that they're supposed to wear sunscreen and stuff, but they probably need to supplement with vitamin D because now they're lacking the healthy sun exposure because of the extra ultraviolet radiation we're exposed to. So my understanding is that the emphasis is on sun protection. And then if you have to take vitamin D, go take vitamin D supplementation, et cetera.
Yeah. And I think that a lot of that too comes that, again, when we go back to causality, the link between UV damage and skin cancer is a much more established link. Then yes, vitamin D is again associated with, many aspects of health. But does vitamin D supplementation actually then, or say improving vitamin D with going out into the sun, does that actually decrease risk of disease? Is a little bit controversial. And so, sunscreen, mineral-based, chemical-based, both fine. I prefer mineral-based. But the reason I actually prefer it more than anything is because it is so thick. You've really got to you've got to rub it in, slather it on. There's no way to apply just a bit of mineral-based because you really have to rub it in to get it, to get it there. That's giving you better overall coverage. And so what I do is, if I'm going to be out in the sun, then I have a base that is that is not going to be very easy to reapply while I'm out at the beach. And so then, that's where kind of the spray stuff comes in. Spray stuff, again, isn't bad. And if that's what you will use, then use that. But you have to really, really, really make sure that you're getting a good application there. And then the biggest thing is actually that reapplication. So I don't care. So again, that, when you start getting up to the SPF of 70, 80, 100, the stuff is going to wash or sweat off before you ever get that extended time. So you're better off with an SPF 50, but reapplying every, hour to hour and a half if you're in the sun, especially if you're sweating or swimming.
And how much of a difference does sunscreen make, or sun health? How much can you reduce the risk of melanoma with the proper hygiene?
You know what?
Do we know?
We should know that number. No, we do. If I give you a number, I'm going to make it up. But
That's okay.
It's a huge amount.
It is a huge amount. Okay. Well, look, yeah. I appreciate everything you're doing. I think that, your work and your colleagues' work in this field, you mentioned Cell and Science multiple times this last hour. And those are some of the, journals that we need to be getting into in this field to really look at the basic science of some of the mechanisms of what we're talking about. And then there's so much crossover between what we're talking about and then, conventional medical oncology and therapeutics and then lifestyle. Yeah. It just brings everything together. And then there's all these applications. So I think it's super exciting and is why most of us are interested in this area as well.
Yeah. Yeah, no, I think the other key part of that is that none of us know all of it. And, now when we're looking at, I'm a melanoma medical oncologist. I am not a dietitian. I am not a microbiologist, and I am not an immunologist, and I am not a nutritional epidemiologist. And so we have, phenomenal collaborators that we work with in a team approach to be able to drive that forward. And I absolutely think that that's what's critical, to hopefully, practice changing discoveries.
Thank you so much. And thanks for joining us today.
Absolutely.